Kia ora, everyone. Welcome to the New Zealand Telehealth Forum's webinar. This is a really great one, and we've had lots of people who've wanted to come and hear from these really amazing people doing amazing things out there. So thank you very much to Sasha from Well Revolution, Jamie from ProCare and CareHQ, Giles from Emergency Consult, and Matadoria from Tend. It's really great that you guys have got the time to join us. Sam Merton and Stephen Child are going to act as moderators for the second part of this section, where we're going to take an opportunity to ask some questions. So we're going to give each of our speakers about 7 minutes to tell us what they've been up to, and then we'll go to the rest of our panel after that. And we are going to start with Dr. Jamie Shepherd, who's obviously struggling again with his Wi-Fi connection. He's beautifully frozen though. Okay, all right. Let's let Jamie try and sort his. Oh, are you there? How's it going, Jamie? He's demonstrating the wonders of modern technology by beaming out. Let's go to Sasha. Sasha, tell us what you've been up to, mate.
Hi, everyone. I'm Sasha Kliakowicz. I'm a doctor and also one of the co-founders of Well Revolution. I don't know how long you want me to chat for. I could go on for a really long time, but I won't. Well Revolution is a digital health platform just like the rest on here. We're a messaging-based platform that's on demand. So we're quite different, no waiting around for appointments. And we work primarily in general practice, in partnership with general practice. The journey to where we are right now has been, interesting. We have been around since 2018. We started with the sexual health service, which was basically about serving a population who we know don't really like coming to see the GP around sexual health stuff. And we learned a lot through that process. They were direct-to-consumer sort of home tests and with digital health kind of back end. From there, we got involved in general practice. I come from a hugely general practice family where I was hearing since I was like little all about the woes of the healthcare system. And we started focusing on the issues inside of general practice. And part of the issues we see time and time again is, we've got to get through so much load as clinicians. We have to become more efficient. We have a health system that's really designed and funded and structured kind of around 1980s kind of thinking. And so from there, we started focusing on the issues that we could see that we could solve. And we've been developing the platform for about 4 years. COVID was an accelerator, a huge accelerator, and we learned a huge amount through the process of launching with general practice in that time. Since then, still learning, still growing, still serving lots of patients, and we're working with MedTech and the ministry in order to get integrations, which I'm sure you guys will want to talk more about over the process of things. But the journey that we've had thus far has been incredibly interesting and, very fulfilling as a clinician to see the adoption of new types of technology, the different players in the mix, how we're all going to develop and change our practice. I think we can all safely say that digital health is here for the long run. It's not something that is a flash in the pan. I think generally our millennials and Gen Z, most of our Gen Xers out there are super okay with anything kind of digital, and they really demand quite a lot and they have super high expectations. I think the health system is failing to deliver. I think we're really working with a system that's very outdated, under-resourced and underfunded, underinvested for a really long time, and often that leads to the structural inequalities that we see within the system. Customers, however, throughout all of our patients, whether you're secondary or primary care, I think are forgiving, but they're also hugely willing to try. And I think we have a great country that wants to do amazing things, and we have a population that want to try and they want to adapt and change. And I think that's really amazing. And I've been really honoured to kind of be a part of that journey throughout the last sort of 10 years or so being in innovation. How much longer do you want me to go, Ruth? Because I could keep going forever.
No, that's great. That's great, Sasha. So how about telling us a little bit about maybe what's been the hardest part? I mean, if you look at 2018 and then look at what the changes that have happened in 2020, you've been in the game for a little bit. What's been the hardest part along the way?
Yeah. Well, having been involved with the ministry and the sort of DHB scene previous to that, I think overall, the hardest part really is integrations, or the ability to play together. Like, I think a buoyant health industry going forward, especially in this digital space, is one where sharing and egalitarianism of data is just normal. And I think at the moment, as I said, in the 1980s, we really structured the way our health system is delivered, especially in primary care. It's focused around hanging on to people, hanging on to patients. There's a real sense of kind of, I own this, it's not yours. And that's kind of permeated throughout the whole industry. So getting people to a kind of a FHIR standard API or kind of an HL7 point where we can actually work together as a system is really the goal. And I think, we are a service-led industry. We're not here to hang on to people's information. We're here to serve. And I think when we can get ourselves to a point where that's the norm, then I think we're really in an interesting place for digital health. But in terms of what's hard, oh gosh, I could also fill up this whole thing just talking about what's hard.
Well, you've given us some really good things to go on to, and I'm sure Sam and Stephen, I can see them writing a few notes there, so I'm sure they're going to come back to you for some more questions. But why don't we take advantage of Jamie, hopefully having now kicked his kids off their Netflix or Minecraft or whatever else they've been doing, and we'll ask him what he's been up to now.
Yeah, look, I've been doing video consults myself in my own practice for just about 5 years. And that really kicked off the conversation at the PHO level. And over time, we've developed relationships across the network, and Southern Cross and ProCare came together to create CareHQ. It's been made possible as part of that partnership. They're both big organisations. Southern Cross represents nearly 880,000 members, and ProCare around 800,000 patients. And it was a nice fit to try and solve some of the things that we see occur within the digital space. We both recognise that video consultations are part of, helping Kiwis keep their lives healthy. We've really seen that with COVID. We've seen that they're happy to adopt it. And we think that, the key to, that kind of success in supporting health is just trying to give people access to healthcare services that meet their needs and in a convenient way. I mean, a big part of the change we've seen is that actually traditional general practice will always have a role. There'll always be a role for face-to-face, and there'll always be a role for that continuity of care. But equally, we need to be working with patients to try and give them the access that they want in the way that they want to. As a co-op owned and PHO owned element, they're also really keen to support local general practice. And we recognise that ongoing relationship from a patient's perspective, that's really key. My patients like to come and see me. They have a relationship with me. I might look after 3 or 4 generations of that family. And that continuity, I think, is really important. But we also appreciate it's not always possible for people to see the GP when they want to or in the most convenient way. And really, the service has started to try and have that, trusted GP video consult option, but in support of what is also good quality independent general practice, and trying to find that niche in the market. Big, it was a really hard thing to kind of work through. What model works to both be valuable for patients, but also fit into the general practice landscape, and that's where we landed in terms of how we function and work. So as a virtual provider, we don't enroll, we don't take clawbacks. And there are some limitations of doing that, which I'll talk about towards the end. But really there to try and provide that extended support process for practices. to give patients an alternative that also, means that our practices feel comfortable in, telling patients to use our services when they need to, long weekends, after hours. It works really nicely in that setting, or whether we're just full today. And how do we manage that patient load when, some days we might have some empty slots and some days we're absolutely jam-packed? And how do we manage load over a bigger period of time without necessarily the competitive threat? And I do think it's important. CareHQ offers two elements of service. So on the patient end, we have a book now. So we have an urgent queue-based process where a patient can see us now. And that urgent queue is just picked up as needed. And we have a booked appointment schedules as well. So we run 7 till 7, 7 days a week, although we are having to extend the hours out to about 9 p.m. And it's really that additional GP service element, an alternative to after hours, and just convenient way with having the people working within it be vetted, and as a practice owner myself, be happy to be able to say, look, to one of my patients, I know you can see one of the GPs here, you'll get a good service, you'll get quality out of what you're doing. That trust for both patients and for practices is a really big part of what we want to try and achieve. And I think that's a really key element to why we think the service works really nicely in that way. Obviously, that's something that we need to continue to develop. And I think there's a lot of myths out there around what virtual health can and can't do, or what it should and shouldn't do. We've seen quite a big move in the general governance area between both the College of GPs and the Medical Council statements around telehealth. And they all came at a reasonably awkward time because they were redone and re-released just before COVID. And then obviously we're still working in an environment which is a bit fluid. I mean, even our prescriptions are still on waiver. We haven't got certainty about that technological future. But on the other hand, we've certainly seen that giving people access is something they really value. Our GPs are all college members. We think that's really important. They all get individual training on virtual care delivery, examinations over video. We run virtual peer groups monthly for all of our GPs who work in the service. And that, I think, helps keep some of the quality and meaning that, as a practice owner myself, I know that, patients should be able to expect an excellent service. And I guess that's one of the things we've definitely learned. We've probably been a little bit surprised by how much people seem to love it. We've got a 95% 4 or 5-star rating across all of our consultations. We think that's pretty incredible as an outcome from a patient perspective. We've seen that there is a genuine impact on access. Young parents, those are mobile, rural people. We see a lot of people from the Central North Island who can't get a GP, can't even register with a GP. We've seen some innovation come out of that as well. We've started a partnership with the clinic in Rotorua where they do our CareHQ consultations in-house to VLCA Māori patients, which I think is fantastic. We've seen septic patients sent to hospital. We've diagnosed Crohn's. We've found colonic masses, things that you wouldn't necessarily expect to see or be solved in a virtual sense, and they can be. I think probably the other thing which has been really interesting is the workforce impact. We've got mums returning to work. We've got GPs looking to phase down from their face-to-face hours without the complexity of having to deal with paperwork afterwards. We've definitely found that there's a lot of GPs looking for some balance, and we haven't had any trouble recruiting them, which has been really quite an interesting thing. I think on the challenges side, there's probably much like normal general practice. There's always issues around how do you manage a consultation digitally, virtually? What happens with technology? What happens with the quality of the camera? If you use a great HD video, it's wonderful. But some of the older laptops aren't particularly good in that setting. There's always risk around missing clinical signs and getting patient history. We are lucky. For most of the country, we get access to the shared electronic health record, and that's been really helpful.
Thanks very much, Jamie.
But there's still that element whereby sometimes there's a limitation from the consultation, and it's really important that we're comfortable to work those through. And sometimes it's not a diagnostic consult, it becomes an advice-based one, but that still creates value for the patient, and they still, clearly do love the service as it's delivered.
I think Tammy's given us a
robust
great example of the audio
systems.
not being quite on there. I'm actually going to just move over now to Mataroria. Thanks, Jamie. And give us a little bit of background as to what you're up to there, mate.
Koutou katoa, ko Mataroria Lyndon tōku ingoa, he uri ahau no Ngāti Hine Ngāti Whātua me Waikato. My name's Mataroria. I'm co-founder and clinical director here at Telehealth and also in my wider mahi. I'm a senior lecturer at the University of Auckland and equity lead within Mahitahi Hauora, the primary healthcare organisation within Northland, Te Tai Tokiro. Here at Tend, we're a team of health professionals, technologists and entrepreneurs who came together really to try and make healthcare more smarter, convenient and easier as well. We launched late last year, but have actually been in development for nearly 2 years now in terms of designing both our services around our patient needs, but also around our workforce needs as well. Our vision is for all people in Aotearoa to be the healthiest in the world through accessible, equitable, smart and high quality primary care. So a big vision, but that's something that we want to be able to embark on for our patients and our whānau. Our goal is to provide the best healthcare experiences by enabling patients to be able to receive care in a way that works for them. From our care team of GPs, nurses and a clinical pharmacist. And that can be either online through secure online consultations or within our medical centres where I'm here based at the moment in Kingsland to be able to receive both physical examinations, procedures and other services as well. So unlike other online primary providers here this evening, we provide a full service primary healthcare general practice service through our Tend platform. And so we enroll patients. We provide both online or in-person care. It's up to the patient. We provide preventative and proactive care, including long-term conditions, cervical screening, immunisations, recalls, health promotion, and also the option to message with our care team to provide both non-linear care, but also improve care continuity as well through messaging, as well as through the online or in-person consultations, as well as the choice to be able to choose online or in-person, choose your clinician, which might, the clinician, some who may resonate or relate to you more on a personal level, but also choosing the time, the day that's convenient to you as well for your appointment. So we offer extended opening hours through our online service, 7 a.m. to 9 p.m. Just to also highlight that through our Māori leadership within Tend, we offer the Tend app in Te Reo, which I understand is probably the first primary healthcare provider to do so. 14% of our enrolled population are Māori, compared with 8% of the Auckland DHB region Māori population where we're based. And 30% are higher needs, so Māori, Pacific or Q5. So we have a real focus on improving equity and access for our patients. And just to tautoko the kōrero so far from Jamie and Sasha about some of those challenges around establishing a service for us, as well as establishing a general practice service, and some of those challenges that a lot of GPs and general practices currently face, not only in terms of, for example, in terms of technology and setting up, including connecting with the various systems. There's over 120 health IT systems nationally, regionally, locally, but also around our workforce. So we have both GPs and nurses, and it's always a challenge around the workforce. But as Jamie's highlighted, through online or telehealth, we think it provides opportunities around greater flexibility for our workforce, around the way that they work, when they work, and how they work as well. And that's something that we provide as an opportunity for our workforce within Tend. And also just to highlight the challenges around sustainable funding within primary care as a general practice ourselves, primary care provider, and the issues around the need to actually have that sustainable funding, but also it takes a lot of funding to be able to establish a general practice and provide the services that we need to. So I just wanted to highlight really our purpose around improving healthcare and equity, particularly for Māori, as a clinical director myself here in TEND, and being able to provide equity of access as well. And I think just lastly, to round out, I think we'd all agree around how we hope that through technology, patients won't have to tell their same story twice. We're able to integrate across different services. And that's why TEND isn't online only, because we wanted to provide the full service, but not be siloed within an online only consultation, but to be able to provide that in-person care and integrate as well with other services, secondary care and referral pathways too. So I think that's some of the kōrero that's been highlighted tonight, and I look forward to that discussion around those kaupapa. Kia ora.
Thanks for having me, Ruth. Thanks for inviting me. Hi, Steve. If you remember me, I used to be your medical registrar all those years ago. So he's probably muted.
The older I get, the more people say that to me. It's not a good sign. Hello, Giles.
Hi, Steve. Good to see you after all these years. Hey, yeah, my background, I'm an emergency physician. I've been doing ED for the last 20 years at Waikato Hospital. But I've also worked in the Australian outback in the austere environment, places like the Northern Territories and Western Australia in the ED. And their telemedicine is established and normalised because while working out there, we had to care for all the acute patients in remote communities before RFDS could get them back into our regional hospital. So that's my background. As I said, there seems to be an underlying nationwide problem in emergency departments, and that's where we think that telemedicine can be an integral part of emergency departments. Ruth would probably know that in the last 20 years, we know that there's long waits, there's long wait times for patients to see a doctor in ED, overcrowded waiting rooms, which are high risk for transmitting diseases like flu and COVID. In terms of overcrowding, my colleague yesterday said at Middlemore, about 440 patients went through the hospital ED, and 90 patients were still waiting for beds. I talked to my colleague in London, he said there's 700 patients went through their ED in one day. So that's the kind of volumes we're looking at now and for the future. I mean, everywhere in New Zealand, there's 10% growth of ED attendances every year. So, for example, in Waikato, in 2002, when I first started and came back from Australia, there was about 20,000 patients come through ED. It's now ballooned out to 90,000, even with a new ED build 6 years ago. So, I mean, that's due to the growth in Hamilton, ageing population, and internal migration. I mean, compounding problem is finite resources in ED, staff, space, bed block. And there's also a fundamental problem of how we see patients in ED. It's all in series. Patient comes to ED, they wait in the triage line, see the triage nurse, wait in the waiting room, wait for a doctor, see the doctor, and then a medical plan is done. That's a lot of time spent in ED and pretty inefficient. And there's also a problem with health equity and accessibility, especially in rural ED hospitals. That's quite a big concern because there's a lot of vulnerable populations in the rural area, especially Maori health. So, I mean, with those kind of problems, a few of us ED physicians, including you, Ruth, thought we could do better and providing expert ED care to all those populations. And it's all about trying to export the experienced ED physicians out of the four walls of ED by telemedicine portal. And I'm not trying to, I mean, Ruth has got all the standard pad, but it's about providing easy and fast access for patients to get to ED consultants. It's also about providing another layer of expert advice when required, especially in a rural sector where they're working in isolation, especially in rural hospitals. It talks about reducing wait time for patients when they come to ED. And a good thing about it is that when they use emergency consult, they get an instant, what's we call force multiplier, which means that either they doubled or tripled the ED physicians at their rural site, which is a benefit because they don't have to go through the HR process of finding a locum. There's also a good, we think we can provide a good circuit breaker for our rural hospital specialists, and which means that you can spread out the work stress and reduce the burnout, because rural burnout in rural sector is pretty high. So, I mean, we're nationwide, we're 24/7, and we're working with different DHBs and different rural hospitals just to help them out.
Awesome. Thanks so much, Giles. So that's 4 very different sort of use cases and developments, which makes for a really interesting panel discussion. And there's some really great questions and answers coming up there. David's obviously particularly enjoying your virtual background, which is a bit windy, Giles.
Sorry.
Don't mind David. He's trying to turn us all virtual.
I believe Giles's background is actually.
I can be mean to him because he can't actually talk to me back. So I'll take the opportunity. What I'm going to do now is I'm going to remarkably for me be quiet and throw the floor open to Sam and Stephen for some question time. So maybe I will just do bounce some questions between you, Sam and Stephen. Did you want to kick off, Sam?
Oh, thanks very much. Thanks for all the panellists. It's been really interesting listening to what you have to say. Some of the questions that we have had come through and is often on people's minds is if you see someone virtually and then they need a physical examination, how do you manage that the costings to the patient and making sure that works out for them? Because this is meant to help with access, but sometimes you end up doing double handling in some ways. Yeah.
I think it's really an interesting question, and I think it comes down to maybe a philosophical point. We obviously work in partnership with general practice and have a philosophy of leaving no practice behind. I think there's a real movement right now that there's some really well-funded corporate entities out there, but we want to be able to bring the rest of our general practice along for this digital ride. When it comes to payment, I think we could all spend a long time talking about this, but my belief is that it should be a one-pay model. That if you're seen digitally and then you need to come in, that's one hit. If you order Uber Eats or go on your phone and order anything on your app, it's kind of one price. And for me, I mean, maybe that's slightly different sometimes if you've got highly complex situations, but for me, I think it's a philosophy I think we might need to think about. It's like, why are we necessarily foreseeing a visit as only online or in person? So for me, I think we have to start understanding that our populations want new things. They want new services delivered in different ways. And I think funding needs, not just co-pays, but funding needs to reflect the fact that an episode might take a few hits, whether it's in person or online. So I think we do have to approach the way we see consultations kind of a bit differently. That's just me though.
That's all right.
I think early on here at Tend, we identified that we wouldn't just be online only in order to provide, firstly, patient choice around how they want to receive their care, but also clinically we felt that we needed to be able to see our patients for physical exams or wider services such as cervical screening. And so we try to integrate, like Sasha says, it's not online or in person, but actually integrating them together. And that's how we've tried to do that through the Tend platform. And so literally, if right now our GPs are seeing patients online, if they need to be seen in person, we'll refer them for a blood test and see you in the morning in the clinic. It's that seamless experience that we've been trying to provide through having the platform and both in-person or online care. In terms of the funding, we don't double charge our patients. It's the one episode. And so hence, if we see them online tonight and we need to see them in the morning, that's not a second consult, because just like Sasha says, we think that it's the one episode, and we think that patients shouldn't have to miss out or be double charged because the funding models aren't able to provide for that type of care. So that's been our approach at Tend, and why we offer both online and in-person through the One Tend platform.
And Giles, how do you manage the service that you provide with for EDs somewhere else? Are you and how does that funding work for providing that service to another hospital or somewhere else?
Sorry, I just had to unmute myself. I mean, we see ourselves as an extension of a public hospital. So when we're working with rural hospitals and rural EDs, we do have to have a good negotiation with the DHBs to fund us. But the funding's already there. We just have to tap into it. Government pays the DHBs for DHBs to see the patients in ED. So there is funding there in the DHB. It's just a lot of negotiations to free up those funds. But the patients don't pay. That's the main thing.
It might change with Health NZ, and we're all in one service. Yeah. I'll leave Stephen to ask some questions now.
Yes, right. So my first comment was going to be, Giles, I'm pretty sure that's Hamilton Island in the background, and I'm sure there was a shark attack there a couple of years ago just off that beach from memory. Am I correct? Anyway, while Giles is hitting mute.
No, sorry, Steve. It's up in Northland. Carry.
There you go. So hopefully less shark attacks up there.
No, there's none. There's no sharks up in Northland. I'm sitting on a beach on my iwi land.
Nice. So I was just reflecting on what Giles was talking about, of the increased numbers that we're seeing in the public EDs. And the ED physicians in my hospital say that some of that comes down to cost and equity. In other words, it is free to see a doctor in a public DHB, but even seeing your GP carries a copay, and all of the systems that you've set up include a copay. I was interested also that Sasha used the word customer. She didn't say patient, she said customer. How, as doctors, are you integrating your ethical obligations to provide care to your patients with a new corporate model in which that patient is the customer and paying the money? So you have an obligation to make money out of this, and yet your medical obligation is to provide the best possible care to your patients. How do you marry those two interests in your new medical practice models?
Well, I mean, it's not a new concept, right? GPs have been charging since the day they started practicing, pretty much. So I think these are two things we have to hold. It doesn't matter if you're working in ED. I mean, I work in ED occasionally as well. So I see what what Giles is talking about. It is tricky because we have to run an efficient system. And if it's completely free, you see the same thing you're seeing in the NHS, which is, again, quite an inefficient system because there is no disincentive necessarily for turning up for little tiny things. So I think you have to hold those two things in balance. And I do think we're here to serve primarily as doctors. But again, we don't have infinite resources. We don't have infinite time. We don't have infinite money. And we have to balance these things out. And I do think you see efficiency if you look at the way different health systems work across how much you can sort of get bang for your buck wise. There is a nice balance, I think, that we've managed to strike over the years with this little juxtaposition of some form of payment, because I think it allows us to understand when they self-triage in a way, when they know they need to go somewhere. However, we do see a big divide where we have people who can't afford $15 for a VLCA, which we've been partnering with a VLCA practice in Northern for a long time. We see digital inequality all the time. People don't have $1 in their account. How do we deal with people who don't have a bank account? How do we deal with people that have a community services card but don't have a working EFTPOS card? We're seeing digital inequality all the time. We've been seeing it for the last 2 years.
I guess that aligns with my question then. So do you think that your service and TEND service and so on, do you think you are decreasing inequality, especially on access, or because of the funding models, are you actually worsening access even though digital is allowing more access? How do you feel you're addressing the access need and inequity?
Well, it's interesting. Having worked with this VLCA practice in Northland, it's been incredibly interesting to watch how it works in practice. I think we see a lot of patients who I suppose would be deemed as sort of lower income through that practice. I think they're all very savvy at getting free Wi-Fi and being able to get $1 in their account. But because we're able to understand who that patient is in practice, so we work with general practice partners. So they know their patients. So because of this, most patients can kind of get around the fact that they might not be able to pay right now. But it's attention. If there's a huge amount of shame, the practice has a huge amount of pain when it comes to money. And this is something we see again and again and again and again. And it's not an easy solution, I think. It comes back to the first point I made when I introduced myself. Integrations. If we know we've got a certain 2% of our population, let's just say, cannot afford to get online because they have these patients, and this is where it's been interesting with Well Revolution, because what we found through the research, but also when we were designing our system, is that actually, I have to say, video consultations are poorly adopted and messaging-based systems are far more used, especially by people who are in a very low access area. The reason is they generally have like cheaper phones which have poor access to the internet. We have lots of rural patients. Messaging-based systems require small amounts of data, which means you can send a video, you can send a photo, and messaging-based text. So we actually receive the information quite succinctly. When it comes to payment, that can often be a bit tricky, but we can get around it because we allow practitioners to decide whether or not they give a consult for free or not. So this is up to the practice to decide how they want to do their own payments. So it's actually interesting. If you enable the population to give what they want to give via a messaging-based system, it means that we actually get quite a lot of good data from the people we really need the data from. So it's been incredibly interesting actually working with a VACL for so long because we're encountering the hardest problems first. So it's honestly been so incredibly interesting, and to help these people that are our people who really need help. These are the kind of people who don't have transport, who can't get in. And if you can enable them with the cheapest phone on the cheapest data plan to get some form of care, that's potentially saving an ED visit because they're getting something.
And Mataroa, would you agree? Same thing?
There's a few points that have been raised here. Firstly, going back to the first point around accessibility and funding. And in the ED in hospitals, since the Social Security Act was established nearly 80 years ago, it's established a two-tier system within primary care where there's been a copay, and hospital doctors like yourselves, you haven't had to confront those issues of funding. And so hopefully within the new health reforms coming, there'll be a look again at the funding model. And I really hope that we're able to extend to reduce fees, particularly for teenagers, to be able to extend some of the subsidies to make it more affordable for patients to access primary care. And so I just wanted to make that first point. Secondly, in terms of TEND, we employ our health workforce rather than perhaps other general practices where they're the GP owner and the provider as well. So I just wanted to highlight that difference as well. As an employed workforce like yourselves in the hospital, we also have an employed workforce here in TEND, which is different from being the owner and the provider. Thirdly, in terms of access equity of access, there's a couple of points that's raised there, and it's partly why with TEND, we aren't online only because people can come to our clinic if they don't have the means to access online. But having said that, as represented by our patient demographic, 14% of our patients are Māori, so we're increasing access. I've had patients who don't have transport, literally like Sasha's saying, but they can connect with us online and have a consult. So it goes both ways around needing to have that physical service there to be able to improve access, but also through technology, you're still able to extend the reach as well for those who can't attend physical locations. Just following on from that too, I think, no, I might leave it there for now, because there was a couple of comments here from some of the chat, which was also saying about how we need to be able to improve access rurally too. And I think particularly telehealth is a means to be able to do that. I don't think that the responsibility of digital access equity doesn't sit at the feet of providers. This is a whole of government issue, including when we looked at COVID and educational access to devices during lockdown. So it's not for TEND or CareHQ or the others alone to be able to combat some of those access issues. We need digital infrastructure that's enabled through primary health organisations, through DHBs, and now through Health NZ, as well as cross-sector, to be able to address these issues of digital access and equity, because it's the same whānau who might not be able to access healthcare, who can't access education as well because they don't have the means to. So I just wanted to say that that's a bigger issue that we can all play a part of, but it's also a bigger picture issue that needs to be resolved around digital equity and access.
Thank you for that. If I can ask also a broader question, and I'm even happy to include Ruth and Sam in this question basically as well, and it's the issue really about continuity and integration. Home care medical already exists to offer a one-off triage service for individual problems. Some of the 7 new providers that launched in 2020 have an integration with primary care, and some don't have an integration with primary care. Are we being old-fashioned to say that, in Sasha's words, it's the 1980s model of healthcare delivery and that patients want continuity of care, and really the modern patient just wants an Uber when they want it and could care less about continuity? Or is continuity still important, and therefore should we be designing systems that are integrated? Why isn't this an extension of home care medical, for example? Why have we had 7 commercial organizations try to solve this problem?
Can I just suggest that actually there's a lot of evidence that continuity of care is a good thing. So I think when we don't know a patient, it's easy to be super cautious and maybe have a tendency to over-prescribe or over-investigate. And we see that often in sometimes in ED departments where people will be seeing someone that they don't know and they practice a more defensive type of medicine, whereas if I saw a patient who I knew really well, may not be ordering that extra test or doing things, I'd be able to say, well, knowing your health condition and how you normally run, then we would be doing this, and we can watch and see, and we have that sort of more cautious approach. So I'd be interested to hear what you do think about the continuity, because I think we can fall into the over-treatment trap when we don't know a person and we're being extra cautious.
Follow on from that, and I think we have to define continuity of care, because there's multiple elements to that, and not just the same doctor or nurse continuity, which is one facet, but also information continuity is one of the aspects of continuity of care as well. And I think in the current workforce where we've seen different practices having locums, it's just a challenge that we face. So I just wanted to broaden out the definition of continuity, where for us, our patients can choose to have the same GP through our service, but also at the same time, some patients want to see the next available doctor. And so it's important that the information continuity is there, so that there's the medical records, and don't get us started on the amount of lack of integration of health information between the sectors or between primary and secondary, for example. But the information continuity is I think is an also important factor to provide that continuity of care as well.
Yeah, and I think patient choice is a good point. Patients kind of are quite good at self-triaging when they want a relationship they know will extend over time, whereas something that they know is kind of episodic. I think that the idea of patient choice is important to really give and empower people to decide how they want to be treated and whom they want to be treated by. I think, again, it's not going to this highly, I don't think anyone here on this panel is sitting here rubbing their hands in glee because there's cash raining from the sky, because it's just not it's just not happening. Like we're all in health because we care and we like what we do and we want things to be better. It doesn't matter what side of the fence you're on, and you might call us all frenemies, but we're really not. We're all here because we want to do this stuff. And frankly, these bricks behind me, I've been running into them for 10 years. It's hard to do this stuff. So we're not doing it because, we're Donald Duck and we want to, cash raining everywhere. It doesn't work like that. So I think, it's just a way of understanding. I think patient expectations are changing. They want different things from different services. The way we've structured the whole health system obviously needs a big shakeup. It isn't just about integrations and data or just about funding or just about service design. I think it's about trying to understand what we're all trying to achieve, which is to help everyone be healthier, to help them get care, to help them live healthy lives. And I think it's going to take a lot of people trying. It isn't just going to be. Personally, I don't think necessarily some things should be solved by central government or by the ministry. I think sometimes setting the conditions for innovation to thrive, that's the kind of things that I hope that we'll get with this reform, that we'll get the ability for funding and design and structure and workforce management to thrive, just set the opportunities up.
So I've got a few hats on. Obviously, when I'm sitting in this Southern Cross, I've got the Medical Council and I'm on the Clinical Governance Group for Home Care Medical as well. So this question, I guess, partly comes with my Medical Council hat on. But how do you feel? Do you feel that the doctor doing the telehealth consultation should continue to take 100% responsibility for that consultation? And therefore, if they missed something because of a lack of physical examination, should they still be 100% culpable? Or is there a case of buyer beware from the patient's point of view if they engage in this? And should there be a rider for all telehealth services in which a disclaimer, if you like, to the patient that we are not 100% accountable because it's in telehealth? Or how should that issue be handled, do you think?
I could start, although Jamie and Giles might chip in as well.
Yeah, I feel like
I think just to say that healthcare shouldn't be on the individual, it's a system. And I think that's just a general principle or philosophy I have. When a mistake happens, as you know, there's a whole system of system factors that happen within that. So that I just wanted to put that first. Secondly, with the latest telehealth guidelines from the Medical Council, you do need consent to provide an online consultation. So I think that's something that also needs to be explicit up front, according to the Medical Council, about the provision of online care. And so I also think that it's not necessarily just on the doctor itself, but also being able to make sure that the patient is informed, but having the clinical judgment as well to make sure that there is in-person care or referral that's provided in the event, based on the Medical Council guidelines, that you're not able to provide the equivalent care online only.
I think the other thing which is really evident is that it's actually no different to what we do every day. Even in my practice face-to-face, I don't have a CT machine. I don't have a radiology provider right in my centre. I don't have ready access to all of those things. And so there are limitations in a face-to-face consult as well. There is, particularly for some examinations, limited value out of physical examination. Sometimes it will give you a pointer, sometimes it won't. Sometimes we can be really certain virtually, sometimes we can be really certain face-to-face, but we can equally be uncertain. And it's the same process and protocol that we run through as clinicians, which is safety netting, documentation, follow-up. All of those things create the safety element around it. I don't think it should be a matter of buyer beware, because it's actually up to us to let patients know where we're not certain, how we've reached the conclusions that we've reached, and to educate them in that space. And where there are limitations, we just, like we do face-to-face, we give the same ideas. And so from that perspective, I don't see that if we look at the telehealth guidelines, I think they're nice to have, but actually they just represent the same guidelines we have face-to-face, just with a slightly different connotation to them, which is you've got to be even more careful. But actually it's just a different place that you're working from. And we always have limitations and we always have uncertainty in primary care. It will continue, and what you do to solve that is actually the important thing.
So a question then that's come through from the chat, and also that I've seen in my practice, is the integration. And everyone's talked about the fact that integration is a dog, and trying to get systems to talk to each other and getting services that come in. And then if you get something that's sent through a PDF, your patient can't see it on the portal, and drama. But trying to get, it would be really interesting to hear what you've looked at for, what is it that you provide as far as, the roundness of your notes, and is that for each of your services, do you have a standard set, like a standardization that you set up? And then the second thing is, what if something comes in the notes, and we get this from Healthline sometimes, these are random things that say child is, I don't know, think about what the other one, vomiting, and sort of like see the doctor within an hour, or there's something random that came through that you sort of go, that you really want me that recorded in the notes. So sometimes there'll be some dispute about what it is that's been recorded that is now forever imprinted in those people's notes. So it'd be good if, Jamie, if you start and we go backwards around, say in Giles and Mataroria and Sasha as well.
Yeah, look, the only templating we do with our physical notes is in the virtual consent process. And we do that to have that safety of the consult set up. Everything else comes down to the individual clinicians. Every time notes are sent, they are reviewed by one of the clinical team, which is either a doctor or a nurse. We do try and keep the quality of notes high, but we also try and keep the content of it valuable. It's really difficult when you're a GP and you get thousands of pieces of paperwork. You just want to know what's the pertinent part. Is there anything which is outstanding? And actually, from our perspective, have we done all of the job? Because we certainly don't want to get into a scenario whereby we've left notes like for GP to chase, because that won't happen in our service. We manage all of our results. We manage all of those processes end to end. And we are there to make sure that information, at least the right sorts of information, gets put forward to the GP. There's no way of getting around it currently. It'd be great if it entered the patient's file in a useful manner. Someone's still going to have to press the file on our inbox note, because it's the only way that clinical messaging works currently in New Zealand. Some of that might be solved by HERA, the new National Health Information Platform, which I hope will help that interoperability space and allow practice to choose how that information might come in. We've been working with a practice in Ashburton who'd rather the notes turned up in their practice rather than as PDFs, but currently there's no easy way around that. And it's just about trying to make sure that our notes don't satisfy what we want necessarily, but what's best for the patient and for their GP, because we are there for episodic care. We're there to support the general practice. And so that is the process that we take for getting information back.
Sorry, I know we only have 2 minutes left, so it's just going to be a very quick question. But ACC noticed that there was a major conversion to telehealth, obviously, for their ACC consultations during COVID, of course. But after COVID, despite a very high satisfaction rate from patients, they're quite surprised at the number of patients that went back preferring a face-to-face consult. What is your feeling? I know I'm asking the converted, basically, but were you surprised at the amount of demand for telehealth over face-to-face, or is it what you were expecting when you started your businesses?
I think COVID just accelerated telehealth both for patients and for the clinical workforce as well. I think healthcare was just catching up compared to other sectors. And I think part of the reason why there may have been a decline in telehealth since our first lockdowns is actually the patients are still demanding it, but the workforce needs to have both professional development and the technology embedded within the workflows, because telehealth is more than just a Zoom and a camera with a patient. It's considering, like Jamie said earlier, like the quality of the connection of the hardware, but also around how it integrates with clinical workflows, clinical practice, in general practice, as well. So I think it's bringing both the patients along, but also the clinicians along through telehealth. And just quickly about the notes. At 10, we use open notes for transparency and empowering our patients to have their health information. So all notes after a consultation are provided to the patient, and if it's a casual consultation, provided to the clinician or and where the person is enrolled as well. And I think the chat functionality or messaging is really important through telehealth, like Tend and others, so that it's non-linear care. So tomorrow, if the patient's got a question about their medicines, they're able to message the care team and have clarification. And likewise, the care team can follow up on the patient. So we need to move away from kind of the linear, kind of only see a GP 3 times a year on average, to having consistency, continuity of care that telehealth can offer, and through all of its fullness of online and messaging and in-person care and integrated with it as well.
I think we all know intuitively that evidence-based medicine and shared decision-making gets the best outcome for the patient. It's not all about clinical guidelines and having it all perfectly laid out. It's a discussion. It's a sitting there in relationship with someone with their values and preferences and wherever they may be from, and that's what gets us to the best point for the patient. We too at World Revolution, the whole chat is documented, whether it's an audio file or a video or a message. It's all out in the open, and same with all the notes. I think understanding where people want to be right now is that this is a relationship. It's a two-way street. It's not paternalism sort of raining down and we decide everything and they do what we say. It's a different dynamic. And I think you asked a question before around who shares responsibility if something goes wrong. Well, in the end, I think, yes, there's system failures and the system has to work to get to a point where we're getting great information, we know what's going on. But in the end, I think these are all relationships. And I think the patient also wants to be involved, and they do take responsibility. Patients do. They'll say, yeah, I didn't take that medication, doc. And you're like, okay, well, thanks for letting me know. So I think it's just we're seeing a shift, I think, in general, at a real macro level, where the way that kind of super top-down agency relationship, which is I tell you what to do and you do what I say, egalitarian, sharing, I think that's really what we're seeing here. And whether it's funding or notes or anything, we're trying to get to this different level here. And I think that's really what we need to see reflected in the way the system enables. I think for me, those are the big key words here, is how does the system enable these things to happen? Because I think inherently the workforce is awesome and we all want to do the right thing by our population.
I think it leaves Giles and Jamie the last response to those questions, and then we might have time to close. Giles, did you want to go first? You're muted.
So it automatically mutes. Hey, in terms of responsibility, I mean, for us in the emergency consult, we know it's a high risk when patients come to ED. So we've pretty got most experienced ED physicians on call who've had over like 15 years of ED experience. So, and when we've got the benefit of in rural hospitals and ED is that when we do with telemedicine, there's a shared responsibility with the patient, doctor and nurse, because we see the patient in parallel with a nurse. So when we see the patient, we discuss history, the nurse can do the examination, do some OBS. I mean, at the end of it, we can do a shared decision-making with the patient. And so that's understanding that everybody, the three key stakeholders, know where the medical journey is going to go. And in terms of documentation, I mean, with the rural hospitals, we integrate ourselves into their rural system. So, for example, in Kaitaia Hospital, we use Concerto. So it makes it easier that the rural specialist knows what's happening with the patient, and it's pretty transparent and open. And obviously, clear documentation, detailed documentation will reduce any errors. And also, in terms of governance, I mean, we usually have a weekly audit of all the patients we've seen through the week and discuss any hiccups and any improvement we can do.
Jamie?
With respect to Stephen's question around why the drop-off, and it's been really interesting. I mean, I've offered virtual consults for every patient in my clinic for many years now, and it has still topped off at about 10 to 15% of my day. And it's not really ever changed apart from when we've had lockdowns. And I think the reason for that, when you talk to patients, really is that they actually like to come and see me, or they like to come and see Sasha. It's just the way that people are. We've found through COVID, we all get a little bit over Zoom webinars and conferences and meetings. It's sometimes really nice to see people face to face. And I think that's been the biggest driver of it. And I do think there'll always be a limitation to, how much virtual healthcare is delivered as a percentage of the overall element. I do also think it's going to increase as patients get more used to it and as they bring more of it on board. And I will always ask a patient when I see them, and I've seen them virtually, the previous visit, and they've come in face to face, why? And they just say, because it's really nice sometimes just to sit down person to person. And I think that's what human beings are like. We love that. We appreciate it. We miss it when we don't have it. But it doesn't mean that there's not a place for virtual healthcare, and that it can provide extremely timely, convenient, and really person-focused. It's their choice. And we should be there trying to make sure that that choice is supported the best that we can.
Awesome. Thanks so much, Jamie. And look, I'd just like to thank our panel. We've had this, really great korero, and I can see there's far more questions than we've answered. There's like 32 questions there, and I popped very cheekily into the chat the suggestion that we get all of you back because I sort of get the sense that we could probably speak for another hour or so, and somebody else has sort of gone, gosh, we should have some consumers or patients or service users, whatever you want to call our whānau out there in the wider world. Just to finish, I'm going to pull Jamie up a little bit on his face-to-face nomenclature, actually, because that's mostly because Pat Kerr texted me and says, come on, tell that Jamie to stop using face-to-face. He has to use in person. Jamie's looking sheepish now.
That is absolutely correct. And there's still that conversation. Is it virtual consult? Is it video consult? I actually prefer consultation because it is that.
Yeah, totally. Thank you. We'll avoid the unreal part as well. Yeah. A reminder to everybody that the New Zealand Telehealth Forum's been around for a decade, and we love to have new members. It's entirely free, and we're supported by the Ministry of Health and the strength of our volunteers. So do feel free to come and join us. For this particular webinar, I think we've covered the gamut of balance and workforce through to balance and bank balances, through to equity and digital inequity, two-tier systems, funding models. It's been a really interesting conversation, which I think and I hope has been really valuable. And I think that pretty much brings us to a close. Once again, thank you to Sam and Stephen, who are our long-standing moderators and do such a great job with their insightful questions and responses also. And to Sasha, Mataroria, Giles and Jamie, thanks again for coming and discussing what's going on in your worlds with us. And to everybody else out there, we'll see you next time. Ka kite anō.